Let's look first at neuropathic pain. So this is a pain disorder where you have a dysfunction in the nerves that carry pain, and you get chronic nerve-derived pain, and it can be a really difficult condition to treat. It's often associated with different disorders like diabetes, where eventually the continued high blood glucose levels can cause a deterioration of the nerve fibers that make them more sensitive, or it can be related to cancer because of the cancer itself, or can be induced by chemotherapy inducing agents that cause nerve damage. So it's pain relating to nerve damage. And this is the area in which we have the best evidence for cannabis-based medicines. We have 15 clinical trials that have been carried out with cannabis-based products in neuropathic pain. 3 of these were phase 3. So remember, I told you that the phase 3 trials are really when we've looked in big patient numbers, in multi-center international trials, and so they're the trials that we really get the best evidence from. It's where we get the most faith that the data is correct. And so 3 of the 15 were phase 3. All of those phase 3 trials were with Sativex. Now remember, also phase 3 trials are really expensive, so they tend to only be done by companies that are trying to get a drug licensed, which is why we tend to only see those phase 3 trials with products like Sativex and the THC products, Nabilone and Dronabinol. Now, of those 15 trials, 12 of them met their primary endpoint. So 12 of them showed a significant reduction in pain in patients who had neuropathic pain. So that really is quite a strong indicator that cannabis-based medicines seem to be effective in neuropathic pain. When we look in a little bit more detail about which products were successful, there were 6 trials with Sativex. 4 of those showed a reduction in pain, and 3 of those were phase 3 trials. So that's, you can see that means this has been reproduced quite a lot in large patient numbers. 1 had mixed results, which means that although the primary endpoint wasn't positive, they did see some positive changes in secondary endpoints, and 1 of the studies was negative. But on the whole, Sativex appears to be successful in treating neuropathic pain. There was 1 small positive trial with pure THC in neuropathic pain, and then there were 8 trials looking at cannabis smoking. 7 of these were positive and 1 were negative, but they were all smaller trials, so phase 2 trials rather than phase 3 trials. So the best evidence that we have at the moment in terms of reproductivity of data in large patient numbers comes with Sativex in neuropathic pain. So in multiple sclerosis related pain, again, this is an area that there has been quite a lot of clinical trial research carried out, and there are 11 trials, of which 9 met their primary endpoint. So again, you're talking about quite a high percentage of these trials were positive for a reduction in multiple sclerosis related pain with a cannabis-based medicine. 3 of these were phase 3, so big patient numbers. And if we look at the detail about which products were successful, 5 of the trials were with Sativex, and 4 of these showed a significant reduction in pain. So that's quite good evidence that Sativex causes a reduction in MS-related pain. There were 5 trials with THC. 4 of these were small and were positive, although 1 was a larger trial and was negative. So I think on balance, we probably still need to do more research in this area to establish whether or not THC is really effective. And then there was 1 small positive trial with cannabis smoking. So the next area that we have quite a lot of clinical trial data is with cancer-related pain. There have been 8 trials in total that have examined a cannabis-based product in cancer-related pain, and 4 of these have met their primary endpoint. So 50% of the trials were positive. So this isn't quite as good as the neuropathic and the MS-related pain. There seems to be something different about cancer-related pain, that cannabis-based medicines may not be as effective, or it may be that the trials maybe weren't carried out as well as they could have been. So we can't say that it's just because the cannabis-based medicines don't work, but so far the data would be inconclusive. There have been 5 trials with Sativex. So again, Sativex is just the most investigated product when it comes to pain disorders in general. 2 of these showed a significant reduction in pain. One of them was a large trial, one was small. The other 3 had mixed results. So they tended to all show reductions in some of the secondary endpoints, which we're going to come to. So patients on these trials often did better for things like sleep and quality of life, but not necessarily for their pain ratings. And remember, pain rating is what these trials are being judged on. But based on this slightly mixed data with Sativex, in Canada, Sativex is actually licensed as a pain reliever in patients with advanced care. So it's as an adjunctive treatment. That means it's an add-on treatment to current standard care to patients with advanced cancer who experience moderate to severe pain with the highest tolerated dose of opioid. So basically, if you are not managing your pain and you're on the highest dose of opioid that you can possibly be on and it's still not working for you, then you can add in Sativex. So it's quite a specific number of patients that would apply to. In terms of, so the rest of the trials were carried out with pure THC. There were 3 trials. 2 small trials were positive in cancer-related pain, but then when this was done in a larger pain population, then the trial data was negative. So with THC, again, it's a slightly more mixed bag, and we would say that this is low quality evidence, and we still need to do more research to establish whether pure THC is effective in cancer-related pain. So let's come back to our hierarchy of evidence triangle that I talked to you about in the last lecture. And I said that I would be judging the strength of evidence for cannabis-based medicines in each of the disorders that I was going to cover in the lectures. So this is what I judge. This is my subjective judgment of where I think we're at with some cannabis-based products in pain according to the clinical trial data that is available to me. So the best evidence that we have is for Sativex, and that's Sativex being used in either multiple sclerosis related pain, cancer related pain, or neuropathic pain. Now remember, part of the reason that we have the best evidence for this is because it is the best investigated product. It is the product for which we have the most clinical trial data in the most patient numbers, and so we can have greater confidence in that data. We have meta-analyses and systematic reviews of this type of data. So if you want to, you can kind of look this up in more detail on PubMed, and you'll find people who have done meta-analyses of these data and come to the conclusions that Sativex can be effective in these disorders. Next probably comes pure THC being used again in either MS, cancer, or neuropathic pain. We have randomized controlled data for THC in these areas. It's a bit mixed. In some of the trials it was successful, but in some trials it wasn't. Possibly better in neuropathic pain than in MS or cancer-related pain. And then underneath here, then we have whole plant products, and this tends to be older data. Remember, that's coming from the 90s and the noughties, and there is whole plant data to suggest that cannabis-based products can be beneficial in MS, but particularly in neuropathic pain. So in pain in general, we have fairly good evidence with quite a lot of clinical trial data that various products are effective in pain disorders. So the last area in which we have a reasonable amount of clinical trial data is in fibromyalgia. And we have 5 clinical trials that have specifically looked at the benefit of a cannabis-based medicine in fibromyalgia. And all of these trials have showed some positive effects of cannabis-based medicines in the reductions of pain, but also in some secondary endpoints like reducing anxiety in the fibromyalgic patients and improving their ability to sleep. So the products that have been tested so far are Sativex. There's one large positive trial with Sativex, and this was in 125 patients. So we have, a reasonable amount of evidence that Sativex can be used for fibromyalgic patients, but this is just one trial, and really to have better strength of evidence, this would need to be reproduced. There are 3 small trials with THC, pure THC, and these have shown positive reductions in pain, improvements in anxiety, and improvements in sleep. But they are small trials, and so in order to strengthen this evidence, we would need to see this in larger patient numbers. We also have one small trial with cannabis smoking showing a positive effect on pain in fibromyalgic patients. So in terms of the hierarchy of evidence, we are in the yellow section, so we do have randomized control data for cannabis-based medicines in fibromyalgia, but we can't yet say specifically which product is going to work or be best for fibromyalgic patients, and we do need to test this in larger patient numbers because the data so far tends to be in smaller patient numbers. So I mentioned that the primary endpoint, the thing on which we judge the success of these trials, is usually pain, because these are pain patients, so we want to know, are these products going to reduce their pain? But we do look at other elements as well, and pain is a very complex disorder that is associated with lots of comorbidities, so that's lots of other problems and symptoms. And these are often get tested or investigated in clinical trials to see whether or not there are improvements in any other aspects of a pain patient's life with cannabis-based medicines. What's really interesting about cannabis-based medicines is there's a whole range of things that are significantly improved in pain patients that are not actually specifically related to their pain. So these are all symptoms that have a significant positive change through randomized controlled data in pain patients. So cannabis-based medicines have been shown to reduce anxiety and reduce depression and improve mood. So basically the mental health of people with chronic pain is improved if they're on a cannabis-based medicine. Their sleep is something that is consistently shown to be improved, and people who suffer with chronic pain sleep badly. And when you sleep badly, that makes your pain worse. And one of the benefits of cannabis-based medicines is an improvement in sleep, which then can help you to tolerate your pain better, but improvements in pain that also help you to sleep better. So it's a kind of a positive cycle. Cannabis-based medicines have also been shown to improve daily functioning. So just your ability to go about day-to-day life and social functioning. So your ability to be out and about, to have social interactions with your family or with friends can be improved with cannabis-based medicines, because people who have chronic pain can really suffer with just going about day-to-day life. There's also been improvements in range of motion. So if you have chronic pain, often that can limit your ability to move around, and cannabis-based medicines have been shown to improve range of motion. There's this thing called a global impression of change, and this can be either recorded from a patient's perspective or from the clinician's perspective. So this is basically saying it's a way of capturing, do you just generally feel better? It's the global impression of how well you're doing. And this is consistently significantly improved when recorded by patients. So patients will say that they generally feel better, and also clinicians will say that they have an improvement in their global impression of their patients. So a clinician will look at their patient and say they seem like they're doing an awful lot better. And so it's taking everything into account, not just pain, but all of the aspects of a pain sufferer's life. So all of these quality of life measures are things that are really consistently improved in cannabis-based medicines, sometimes when the pain itself isn't actually improved or the pain rating isn't changed, but you can have positive changes in all of these other aspects, which are also so important to people who have chronic pain. And something which is also often recorded by pain patients is that they really prefer the side effect profile of cannabis-based medicines compared to their standard analgesics. And many of the strong pain relievers that are out there have significant side effect profiles, so physical impacts such as constipation, but also mental impacts such as mental cloudiness, just not having the same range of emotional emotions. So they basically feel emotionally stunted on many of these drugs, and they can impair their memory. And these are all they all really significantly impact a pain patient's ability to go about day-to-day life, and they will report that cannabis-based medicines really improve their ability to do that, so they don't have all of these side effects that standard analgesics have. So what about other pain conditions? We've talked about the areas that we have the most evidence in, the best evidence for cannabis-based medicines working, but there are lots of other types of pain conditions that we know anecdotally people find cannabis useful for. So the first that I'm going to cover is arthritis. So this is something through survey data consistently people will say that cannabis-based medicines improves their arthritis. But what do we have in terms of clinical or scientific evidence to back that up? So we have widespread anecdotal use, but actually we have very little clinical trial data on cannabis-based medicines in arthritis. There is one positive trial with a medicine called palmitoyl ethanolamide, or PEA. And PEA is actually an endocannabinoid. It's a compound that we make in our body that is similar to those that are found in the plant. So it's an endocannabinoid molecule, and it has been shown to significantly reduce pain in patients with arthritis. There's another compound or another medicine which is a FAAH inhibitor. Now, FAAH is the enzyme that breaks down endocannabinoids. So the cannabinoids that we make in our body normally get degraded by enzymes called FAAH, fatty acid amide hydrolase, and that limits their ability to work in the body. So if you block that enzyme, what you effectively do is you increase the amount of endocannabinoids in your body. This FAAH inhibitor, it's a way of increasing your endogenous endocannabinoid tone. A FAAH inhibitor was found to not be effective in a phase 2 study of 74 arthritis patients. So increasing endocannabinoid tone in these patients was not sufficient to reduce pain. We have one positive phase 2 trial in 58 patients taking Sativex for 5 weeks, showing a significant reduction in pain. And so in terms of the hierarchy of evidence, we're kind of low down in the clinical trial RCT yellow section. We have some data that Sativex can work, but that's just one study and really needs to be replicated. Some data that the endocannabinoid PEA can be effective in arthritis, but again, that's just one study. So despite the kind of wealth of anecdote that cannabis-based medicines are useful in arthritis, we have very limited clinical trial data to support this idea. And again, we don't know which compounds would work or which compounds would be best. So what about endometriosis? This is another area where we have anecdotal evidence that cannabis-based medicines can be useful for patients that have endometriosis. There is survey data to suggest that some women self-manage their symptoms of endometriosis with cannabis, and that's published data. Again, this compound PEA, the endocannabinoid, has been shown to significantly improve chronic pelvic pain, and dysmenorrhea, so this is problems with your menstrual cycle, and improve endometriosis in patients. And there is actually quite a number of studies that have been carried out with PEA on this. So we have a meta-analysis that shows that PEA is effective. So remember, in the hierarchy of evidence, meta-analysis is very strong. It means that we have multiple trials that were carried out in the same type of patients with the same medicine, measuring the same endpoints that we can statistically compare. And this meta-analysis suggested that PEA was effective in patients with problems relating to obs and gynae. There is preclinical data, so there is scientific literature from animal studies to suggest that the endocannabinoid system is quite involved in the pathology, so the development of the disease of endometriosis, which means that with that knowledge, with that scientific knowledge, we should be able to apply cannabinoids in the appropriate way to help relieve symptoms or even to affect disease progression. But that's very early on in the pipeline, in the drug discovery pipeline, and it hasn't been progressed yet. And there is one set of data to suggest that THC is effective in a mouse model of endometriosis. So again, this suggests that there's a potential role for THC in this area, but it's still at a preclinical level and it hasn't been tested clinically. So in terms of our hierarchy of evidence, we're quite low down in the triangle here. We have anecdote and we have survey data to suggest that people find cannabis-based medicines beneficial, and we know that there's a problem with the endocannabinoid system in the pathology of the disease. And we have some animal data to suggest that THC could be effective in endometriosis, but what we don't yet have is any kind of randomized controlled data to test this clinically. So what about headaches? Again, headaches is an area that people have been using cannabis for, really a very long time. There are historical published case reports of people using cannabis for headache disorders and for migraines from the Victorian ages. And there are multiple case reports, so individual patients where there has been successful treatment of migraines with cannabis. And there's also multiple published surveys to report that patients use cannabis to treat their migraine, cluster headaches or headaches. So this is all anecdotal observational data to say that cannabis can work for some people in the treatment of headache disorders. There's one clinical trial that has looked at pure THC, so nabilone, it's a small trial in 30 patients, but they found that nabilone was successful at reducing headache pain in this randomized controlled trial. So we have some early data to suggest that there is effectiveness of THC. But cannabis has also been reported to trigger headaches in some patients. So I think this is still an area that really needs quite a lot of research to figure out what products are beneficial and at what dose. So this may be a dose-dependent effect that you see, a beneficial effect of THC on headaches at low doses, but higher doses can trigger headaches for some people. So in terms of the hierarchy of evidence, it's a bit like the endometriosis story that we're quite low down in the triangle. We have quite a lot of case reports and survey and anecdote data to support the use of cannabis-based medicine with one small randomized controlled trial, but really not enough data to suggest that there is a benefit of cannabis-based medicines in the treatment of headaches. So I've already alluded to the fact that pain ratings may not be the best way to judge how effective a cannabis-based medicine is in patients with pain. And this is some really interesting data that came from a study looking at cannabis at reducing pain in patients with cancer. And they measured pain severity using a pain rating score, but they also asked the patients to rate their ability to cope with pain. And what they found was that there was a small reduction in pain severity, so how patients ranked the pain, that wasn't quite significant. So it wasn't significantly changed by cannabis after 4 months of treatment. But what they found was patients really rated their ability to cope with pain as being very much improved by cannabis. So what cannabis might do for people who have chronic pain is affect their ability to cope with pain and act as a distraction from the pain more than actually affecting the pain rating itself. So it's just that they can tolerate the pain better. And so maybe in these trials where pain ratings have been recorded as the primary endpoint, we weren't necessarily asking the right question, and maybe more of the clinical trials that have looked at cannabis-based medicines in pain disorders would have been successful, would have reached their primary endpoint if we were measuring something different other than just a pain rating.